I think we'll get started tonight. I'm just looking at the audience here, and it's about double the crowd, I would say, that we had from last year. And I think that represents a tremendous increase in interest, and tonight, hopefully, you'll gain some knowledge about Lynch syndrome. And just to introduce the topic, you probably know that HNPCC, or hereditary non-polyposis colon cancer, is really now called Lynch syndrome. So that I don't want everyone to be confused that we're talking about two different things. I am Zane Cohen, and I'm the director of our Digestive Diseases Center, and it's my pleasure really to be here tonight to introduce all of these speakers. I think you'll really find it quite interesting. First and foremost, I want to thank Anne McLaughlin and Joe Aiello for sponsoring this evening's activities, and to recognize people that you probably already know are genetic counselors. I'll ask them to stand as I mention their names: Melissa Aronson, Kara Simoviak, and Spring Holter. These are the most valuable people in our familial gastrointestinal cancer registry, and they are the ones that really are giving me recommendations for Lynch syndrome patients and their families. I also want to thank the volunteers that we currently have working in our center: Emily Bonifero and Maddie Shugar, and of course our support staff, Francis and Paolo, and very importantly Hardin Wang, who is does a great job for everyone in the center in the informatics department. So tonight, I'm going to introduce the speakers, because from your program you'll see that Steve Gellinger is going to introduce the speakers, but he's caught up in the operating room at the moment. He may be able to join us a little bit later. I hope that he will. But our first speaker tonight is Rob Gryfe. Rob is the colorectal surgeon and surgical oncologist and IBD surgeon. He's doing it all, who has Mount Sinai and has a specific interest in the familial gastrointestinal cancer registry, and in particular with hereditary cancer and Lynch syndrome. I'm going to ask him now to speak on the latest research in Lynch syndrome.
Thanks, Zane. It's really a pleasure to speak tonight. I welcome you all, and I would echo Zane's thanks to the various people involved in the FGICR, and tell you that they really do tremendous work, and it's a testament to the fact that there are so many people here tonight. And I've been asked to speak to you about highlights in terms of the latest research in Lynch syndrome. I think I recognize many of you. I might recognize more of you if you stand up and turn around. But tonight, the topics that I'm going to be covering are recent developments in colorectal cancer risk and surveillance, gynecologic cancer risk and surveillance I'll be touching on, but there will be a talk by Dr. Ferguson shortly. Other cancers that are implicated in Lynch syndrome, and then finally about aspirin. I think that's on a lot of people's minds, so I put it last so that you have to stick till the end of at least my talk. So the FGICR is actually quite huge. There's many thousands of patients and their families that have been registered through our familial GI cancer registry. And for tonight's talk, in addition to talking about a bunch of things that have been published recently in the literature, I'm also going to focus on our own experience. And This first slide mirrors what our own experience is, at least up until a few months ago. The numbers are actually higher as of today. So the data that I'm going to speak about involves more than 1,000 germline mismatch repair mutation carriers, so more than 1,000 individuals with the known mutation causing Lynch syndrome from 355 separate families that are registered at the FGICR. And the breakdown in terms of the genes involved are the largest two contributors are MSH2 with just over 50% of the mutations in our registry, and MLH1, which is about 4%. And then the other three genes, MSH6, PMS2, and more recently a gene called EpCAM, which actually has a sort of an unusual mechanism but basically affects the MSH2 gene, have been implicated in a modest number of families in our registry. And these numbers very much mirror numbers that we see in other registries throughout the world. Our breakdown is slightly female predominant in terms of patients in the registry, with just over 55% being female. So in terms of, it used to be an HNPCC, hereditary non-polyposis colorectal cancer. It was recognized for many decades now as a colorectal cancer syndrome. So I'm going to first start with our own data and then clinical research, recent clinical research in terms of colorectal cancer risk. So looking at our own data, what we see in terms of colon cancer is that for the major two genes, for MSH2 and for MLH1, men have a much higher lifetime risk of developing colon cancer as compared to females. So with the MSH2 gene, it's just under a 70% lifetime risk to 70 years for men, and with the MLH1 gene, an 85% lifetime risk in terms of developing a colorectal cancer. And the risk is about half to two-thirds that in females, so 53% or 46% for the MLH1 gene. Interestingly, we also see a difference not only between men and women in terms of the likelihood of developing colon cancer in their lives, but also as to your likelihood based on what gene is actually mutated in your family. So MSH6 and PMS2 carriers have significantly lower risks compared to MSH2. So 25 to 40% in men and 28 to 43% in women of developing colon cancer if you're an MSH6 or a PMS2 carrier. Well, it's been known for quite a long time that regular colonoscopy leads to a reduction in colorectal cancer-related mortality and Lynch syndrome. And that's actually, even though colonoscopy is kind of a given in terms of colorectal cancer screening, it's actually in Lynch syndrome that is the best evidence that it not only detects cancers, but it reduces the likelihood of dying of colorectal cancer. There is not nearly as good evidence for colonoscopy anywhere in the literature as there is in Lynch syndrome. And that at least dates back in terms of you obviously can't run a clinical trial with the parachute anymore. You can't throw somebody out of a plane and randomize somebody to get no parachute. But this all comes back to a trial that was done and published in 1995 from Finland, where they looked at a 10-year experience of individuals with Lynch syndrome, and quite a small number, 250 people. And a lot of these would have been clinical diagnosis as opposed to a genetic diagnosis. But what they did was they looked at whether they had an initial screening colonoscopy, or in those days it could have been a barium enema and a and a flexible sigmoidoscopy. And then they either put you in a group where you would have follow-up screening, surveillance in 3 years, or you would have just the initial assessment, and then if you develop symptoms, you would be seen. And basically, in a 10-year period, in the screening group, there were 4.5% of individuals developed colon cancer, and in the individuals who did not undergo regular screening over the next 10 years, 3 times that number developed colorectal cancer. And this really showed us that we can prevent colorectal cancer by colonoscopy. And again, I don't think this is news to anyone in the room here, but that has to do with the fact that colonoscopy is not only a diagnostic tool, but it's a therapeutic tool. So we can find polyps before they become cancerous and remove them, or in the case of any type of screening tool, we can find potentially not just precursor lesions and deal with them, but we can find cancers in their earlier stages where they are more treatable and more likely the treatment will lead to long-term survival. More recently, there was a Dutch study looking at a substantial number of patients with Lynch syndrome, and they found that in this number of people, 4%, a similar number to the Finnish study above, developed colon cancer while on surveillance, and it's going to happen. And they looked at the interval where they developed colon cancer. So a very, very modest number developed colon cancer within 1 year of their previous colonoscopy, 6%. This is 6% of these 33, so 6% of 4%. And a much higher number developed colon cancer in 1 to 2 years, and a higher number still developed colon cancer 2 to 3 years out from their previous colonoscopy. And these have really led, these two research endeavors have led to the background for the most recent guidelines. And for my talk today, I'm going to use the European guidelines because they've actually just been published in the last month. So most groups go through periodic updates of guidelines. So we go by NCNN, North American, Canadian guidelines, but they haven't been updated for the last few years. So the European guidelines, which were published within the last month, reflect the latest in terms of what's known in the clinical literature. And so the European guidelines recommend a 3-year interval between colonoscopies as being proven to be effective, and that's a very high level recommendation, a grade B recommendation. But they go on to say, in view of advanced colorectal cancers being detected between 2 and 3 years after colonoscopy, the recommended interval for Lynch carriers should be 1 to 2. But they acknowledge that the level of evidence for that is not as good, because I'm sure none of you are going to be willing, again, to go back to this type of study where we randomize you to no screening. And not that I would blame anybody in this room, but there are limitations to how scientific research can be conducted and data accumulated. Well, what about moving away from colorectal cancer? And as many of you know, endometrial cancer is a very common cancer in Lynch syndrome, and as well, ovarian cancer is quite common. So here I've summarized our risk estimates in terms of lifetime risk for women with Lynch syndrome in the familial GI cancer registry at Mount Sinai Hospital in terms of developing endometrial or ovarian cancer. And I put the colorectal cancer numbers down at the bottom just for comparison. So the first thing you'll see is that the risk of endometrial cancer is similar to the risk of colorectal cancer. So it's about 45 to 50% risk in terms of MSH2 and MLH1 carriers. so for colon cancer, and about 50 to 55% lifetime risk for MSH2 or MLH1 carriers in terms of developing endometrial cancer. There, as well, for MSH6 carriers, they seem to have a similar lifetime risk. I realize the number is slightly higher here, but also our confidence in that number is not as great because we have far fewer MSH6 carriers to base that on. So this is what's known as a standard, a 95% confidence interval. So the truth is that the numbers are the same. However, in comparison, PMS2 carriers rarely in the literature and never in our own experience develop endometrial cancer. Another thing that we see through our data is that, mirror the world literature, ovarian cancer is far less frequently seen in Lynch syndrome as compared to endometrial cancer. And something that some groups have seen but not other groups have seen that we have seen here is that MSH2 carriers appear to have a higher risk of ovarian cancer compared to MLH1, MSH6, or PMS2 carriers. And this isn't seen by all groups, but it certainly, we do mirror other groups that have seen this. This isn't novel to ours. So your risk is really dependent on what your family's mutation is, and these things are extremely relevant if you're considering something like prophylactic surgery, which I'm going to guess that Dr. Ferguson is going to speak about shortly. So in terms of gynecologic cancers, surveillance, again, from the recent guidelines, in Lynch syndrome, the risk of developing endometrial cancer equals the risk of developing colorectal cancer. There's lots of data to support that in women. But the value of endometrial cancer surveillance is still unknown. I haven't gone through to review that. I'm not sure if Dr. Ferguson will or won't, but I will summarize by saying that there actually is no good data yet to support surveillance. It's not to say that there aren't surveillance guidelines, and in fact that's what I'm going to summarize with, as the final line here, is that despite that, the European group has recommended that gynecologic exam, transvaginal ultrasound, and aspiration biopsies starting in the mid-30s may lead to detection of pre-malignant disease and early cancer. But this is a grade C recommendation. In other words, the level of scientific evidence for this is quite poor. It's more theoretical. So, well, why don't we call it HNPCC anymore? Well, we've already talked about the fact that women with Lynch syndrome are just as likely to get endometrial cancer, and as well they develop ovarian cancer. But in fact, there are lots of other cancers that are seen in Lynch syndrome. There's a formal criteria called the Amsterdam 2 criteria, which recognizes not only colorectal cancer and endometrial cancer, but small bowel cancer, ureteric cancer, and transitional cell cancer of the kidney, what are called sebaceous adenomas and carcinomas. These are unusual skin-associated cancers, and a non-malignant lesion, a non-cancerous lesion a skin lesion called a keratoacanthoma, as being Lynch associated. So to be defined as a Lynch family, you can have any of these. In addition, the Ontario Ministry of Health and other groups include not only these cancers, but stomach cancer, hepatobiliary cancer, so cancers of the pancreas and bile duct, and as well primary brain cancer. So that's not, frequently cancer goes to the brain in terms of a place that it spreads to, but these are cancers that are primary to the brain, starting in the brain. So all of these are seen more frequently in Lynch syndrome than in the general population. And I'm just going to talk briefly about the risks of those and what we know about that. So again, going back to our own experience, here I've looked at GU stands for genital urinary, so these are the ureteric and renal pelvis cancer, stomach cancer, pancreas and bile duct cancer, small bowel cancers, primary brain cancers, and here it's not the benign, but just the malignant sebaceous lesions, so sebaceous cancers. So what we can see with all of these that define Lynch syndrome is that males are at significantly higher risk compared to females. So any particular one here, so for renal pelvis and ureter, men have about an 11% lifetime risk, while women have a modestly smaller 10% lifetime risk. But every single one of these is higher for men than women, and overall the likelihood of developing a non-colon, non-endometrial, non-ovarian cancer is about a third of men and about 20% of women. As well, another thing that we see is that MSH2 carriers are at a higher likelihood of developing an extracolonic, extragynecologic malignancy as compared to MLH1, MSH2, PMS2, or EpCAM. And here again, these are the cumulative numbers, so about a third of MSH2 carriers will develop one of these types of cancers, and anywhere from 0 in PMS2 or EpCAM to about 15% of MSH6, or half the number of MSH6 or MLH1 will develop any one of these, and then the individual numbers here. Within our registry, the kidney and ureter is the most common site, and then the next most common site is stomach, pancreas, and bile duct in the order that you see. So I'm going to just talk briefly about a few of these cancers. So urinary tract cancers, as I say, this is the most common site outside of the gynecologic cancers and colon cancer. And depending on the literature, 5 to 20% of individuals with Lynch syndrome will develop one of these. And our experience mirrors what the literature says, so we see this more frequently in males and more frequently in MSH2 carriers. There's only been one study published to date looking at surveillance for these, and it was a Danish study. And it was a population-based analysis, and basically they looked at the entire population of Denmark, and they had just almost 3,500 patients with Lynch syndrome, and they had matched them up with almost 1,000 urine cytologies. And what did they find out from that? Well, they found out that cytology diagnosed 2 asymptomatic cancers. So 0.1% of their cytologies led to diagnosis of asymptomatic cancer. It's not an invasive test that sounds pretty good. However, 22 times, so 10 times that number, they were false positives. So in other words, a pathologist looked at the cytology and said, I think there's cancer here, and then there was a bunch of investigations and there was no cancer there. So for every time you diagnose a cancer, you're going to have 10 people that are shocked and alarmed and in fact don't turn out to have cancer, which might still be acceptable. However, the last number I think is the real kicker. Of this population of more than 3,400 Lynch syndrome patients, 14 developed ureteric or renal pelvis cancers, and 5 of those were individuals who were undergoing screening urine cytologies that were normal. So in other words, the test said that there wasn't a problem and there was a problem, and so unfortunately the screening didn't lead to early detection. So it's a lot of false positives, and then and a lot of what we call false negatives, people who have the disease and it's still not picked up by the test. And because of that, the most recent guidelines do not recommend surveillance outside of clinical research. Now, again, if you fall into an MSH2 family or a family where we've seen it, I think our own registry's approach to this has been to do screening, but this would be poorly supported by the scientific literature. It's just basically the best that we can do. Well, what about small bowel cancer? Quite a bit less likely, 5% lifetime risk, which again, this is in the literature and mirrors our own. There's no evidence of family clustering. In other words, it's unlikely that any particular gene seems to lead to a lot more of this, but that might be just because it's just rare in all. Now, small bowel cancer is incredibly rare, period. So 5% is a very, very high relative risk to the population. But in fact, obviously, 95% of patients with Lynch syndrome will never get small bowel cancer. There's only been one study looking at screening for small bowel cancers, and it was published out of France a few years ago. They looked at 35 patients with Lynch syndrome, and they compared what's called capsule endoscopy versus what's called CT enterocolysis, and here's just examples of those. And what they found was that the capsule endoscopy detected 2 small bowel adenomas, so the precursor, so that's a good thing. We like screening tests that find the precursor to cancer, and 1 small bowel carcinoma, so 1 cancer, and the CT enterocolysis missed the adenomas. So, you know, this study, it's hard, this is the only literature that there is looking at surveillance for small bowel cancer, and basically it just talks about the performance of the test in a grand sense. But given how rare the cancer is, the European expert guidelines as well as North American guidelines, but the most recent, do not recommend any type of routine small bowel cancer surveillance. So I'm going to move on to stomach cancer, gastric cancer. Similar to small bowel cancer, about 5% chance of developing stomach cancer to age 70. There's no evidence, again, in the literature at large that this clusters in families or to a particular gene. There's only one study, again, different country, from Finland, and quite an old study, looking at trying to detect stomach cancers as precursor lesions, and they did not find that it was effective. And interestingly, while the European guidelines do reflect that in terms of not recommending gastric cancer surveillance, they do recommend H. pylori infection testing and eradication therapy if needed. Now, they acknowledge that that's a poor level of support. But I would say that the study that they actually quote for that is really poor. And I'll just very briefly tell you what the background is to this. So there's more or less 2 types of stomach cancer. There's what's called a diffuse type and an intestinal type. The type that occurs more commonly in Lynch syndrome and more commonly in general is the intestinal type. And it happens to be that there are precursor lesions to this, and there are also a precursor infection. I'm sure many of you in this room have heard of H. pylori. It's actually common in just the lay news in terms of it's a stomach infection. And H. pylori causes chronic gastritis and a condition called atrophy. And then the cells in the stomach change, just like how your colon changes to polyps, to what's called intestinal metaplasia, and then ultimately to intestinal type gastric cancer. So, that's why, in theory, I guess, checking for H. pylori might prevent gastric cancer. However, in this Finnish study, they found they were actually comparing Lynch syndrome patients with non-Lynch syndrome patients, and they found the exact same rates of gastritis, H. pylori, atrophy, and intestinal metaplasia in the non-Lynch syndrome patients as the Lynch syndrome patients. So really the study that sort of supports this poor recommendation the literature doesn't support it at all. And I must say, the North American guidelines don't recommend this, and to date we haven't been recommending it to date. But I feel pretty comfortable. I'm going to throw in as my last slide before talking about aspirin something very recent and I think probably not on a lot of people's radar. So prostate cancer, as everyone knows, is a common cancer among men, and generally it has a good prognosis. Well, there's actually been 4 studies, and I'm just going to emphasize the best and latest 2 studies that actually show that the rate of prostate cancer in Lynch syndrome is significantly higher than it is in the population at large, despite how common it is in the population at large. So there was an American study published this year which showed that the likelihood of developing prostate cancer in the background of Lynch is just over 6% by 60 years and 30% by 80 years. And when they compared that to the population, that was twice as high in Lynch patients as patients who don't have, as individuals without Lynch. And then another study looking at data from Germany and the Netherlands that was published last year that showed that there's a 10% risk by age 70. And in fact, when they compared that to the general population, it was 2.5 times that. And they saw that MSH2 was the major culprit. So in other words, that germline carriers of MSH2 had about a 20% risk to age 70 males of developing prostate cancer. That being said, the European guidelines, despite this literature, do not have Lynch-specific guidelines for prostate cancer, and I'm going to explain that. And the reason for that is, despite the fact that prostate cancer is very common, Cancer Care Ontario, which is in charge of guidelines for and all kinds of other things in terms of cancer care for the province, that specifically does not recommend population-based screening with prostate-specific antigen, or PSA. And the reason for that is that PSA is high a lot of the time, and yes, it might indicate prostate cancer, but prostate cancer, if we even just, first of all, it has, just like the other tests, false positives and false negatives, but even if prostate cancer is quite an indolent cancer, so in other words, just because you diagnose it doesn't mean that you have to treat it. That's number one. And number two is that if you do treat it, so surgery or hormonal treatment or radiation, these types of treatments have very significant side effects. So, it's sort of analogous to saying you wouldn't want to kill a fly with a bulldozer. So you don't, and so because of that, surveillance has not been proven on a population-based level for prostate cancer, and even with this increased risk in Lynch syndrome, there is no surveillance specifically recommended for prostate cancer. So the final thing I'll be talking about is aspirin. So there were some trials that have been published in multiple multiple publications over the last few years. And the trial is the CAP2 trial. And the one specifically looking at the long-term outcomes in terms of aspirin use in patients with Lynch syndrome looked at more than 1,000 patients worldwide with Lynch syndrome. And basically, they were put on 600 milligrams of enteric-coated aspirin versus a placebo every day for about 2 years. And interestingly, they first published a few years ago, and they showed no difference in colorectal cancer or polyps at the end of the intervention, which, as I say, was just over 2 years, but ranged from 2 to 4 years in individuals. So, in other words, when the people were on it, for those 2 to 4 years, they did not see any difference in the number of polyps, the number of cancers, the size of polyps, the stage of the cancers, lots of different ways of looking at this, and it seemed to be a negative trial. In other words, it did not support that aspirin was going to help in terms of preventing colon cancer. But they followed up more recently, and what they did was they looked now on average a couple of years later. So the people were on aspirin for on average about 2 years, and then they were followed from anywhere from 1 to 10 years, but on average about 4.5 years. And what they found was that 4% of the individuals on aspirin developed colon cancer after this average 4.5 year follow-up, compared to about 7% who didn't take aspirin during that time. So it's a significant reduction, but it's a modest reduction. It reduces your risk by about 1/3. So 2/3 of the people will still end up getting cancer, but about 1/3 of the people it seemed to be preventable. In addition, they looked at other types of Lynch cancers, and they saw very similar numbers. So about 4% of individuals developed other Lynch-associated cancers, and about 5.5% developed who were on aspirin versus about 5.5% who were on the placebo for those couple of years. So it not only seemed to prevent colon cancer, but it also seemed to prevent the other cancers in Lynch syndrome. This study, the CAP2 trial, also looked at resistant starch, which is basically a high fiber supplement, and they in the same type of fashion. So you either took that on a daily basis or you took a placebo. But they found in publications, sort of in review of that intervention did not reduce the risk of colorectal cancers in Lynch syndrome. So basically, the European guidelines have said that regular aspirin significantly reduces the incidence of cancer in Lynch syndrome, and this is a grade A. This is a randomized controlled trial. This is the strongest type of medical literature that we have. But they also went on to talk about other studies, which I haven't summarized here, but there have been a lot of studies done on aspirin for heart disease, for stroke, for peripheral vascular disease in far higher numbers, because those are problems for the entire population as opposed to individuals with Lynch syndrome. And from those studies, if you look at those populations and then look at colorectal cancers and colorectal polyps, it looks at like low-dose aspirin, so baby aspirin, 81 milligrams a day, is a reasonable option to discuss with Lynch carriers. In other words, in those studies, that's not the Lynch population. Even low-dose aspirin was associated with a reduced risk in terms of colorectal polyps and colorectal cancer. Now, I think, and it isn't as strong in terms of scientific literature, so that's a grade B recommendation, but I think it's really important to recognize, I mean, aspirin is not without consequence, and the dose that was used in the CAP2 trial is a very, very high dose of aspirin. So aspirin can cause problems in terms of stomach bleeding, it can cause problems in terms of kidney failure. It's not, there is no such thing as a free lunch. And so obviously with any type of intervention, we're looking at the minimum effective dose. And because of that, the recent European recommendations are to discuss the risks and benefits and current limitations in the literature in terms of aspirin use. And it seems to sort of say, yes, there's the best evidence for this high dose, but we should probably be considering a lower dose. So just in summary, colorectal cancer, the risk is higher in men as compared to women, and it's higher in MLH1 and MSH2 carriers as compared to MSH6 and QS2 carriers. And for Lynch syndrome carriers, we recommend a colonoscopy every 1 to 2 years. In terms of endometrial cancer, the risk is similar in terms of lifetime risk for endometrial cancer as compared to colon cancer. I'm going to leave the rest of the discussion of that to Dr. Ferguson. In terms of ovarian cancer, the risk appears to be higher in our group than in others for MSH2 carriers. And in terms of the other cancers in Lynch syndrome, they're more common in men, they're more common in MSH2 carriers. But despite the fact that we know about these cancers, there are in fact no specific effective surveillance guidelines for any of them. And then finally, aspirin, we see that it reduces the risk of colorectal cancer by approximately 1/3. And I would say there is still a level of controversy as to what dose individuals with Lynch syndrome should be recommended. And I would emphasize that I think that that is an individual discussion that should be had with each person and their physician, because there are risks to aspirin, and certainly you want to weigh the benefits with the risk. Thank you.
Thanks very much, Rob. I want to tell you that we're going to have a question and answer period at the end, so you'll have lots of time to ask questions. And also, just before I introduce Sarah Ferguson, I just want to put this into perspective that the Lynch syndrome, we're dealing with a relatively rare problem. If you think about colorectal cancer in general, it's probably the 3rd most common cancer, and it leads to death, second highest leading cause of death, cancer-related. So the hereditary